Hi everyone. Our inflammation presentation is on meningitis given by myself, Yalu, Becca, and Micah. The etiology on meningitis is an infectious process caused by bacteria, virus, fungus, or a parasite. Although it is infectious, the inflammation is what ultimately causes morbidity and mortality. The organisms listed in the table are the usual causes for each of the lifespans for neonates, children, adults, and the elderly. This chart lists the additional possible causes if no organism is isolated via culture and sensitivity of CSF fluid. Listed in this table are examples of different viruses that can cause meningitis, such as HIV for aseptic meningitis, TB, Lyme disease, or parasitic infections. Okay, for pathophysiology, the entry of the organisms are via the upper respiratory tract, bloodstream, or they can also enter through a penetrating wound or fractured sinuses in the basilar skull fractures. These patients should be on droplet precautions and proper equipment should be used. This chart shows the pathophysiology in a simplified format. The immune response starts with the release of endogenous cytokines, and the inflammatory response is what leads to increased intracranial pressure. The inflammation is caused by the purulent secretions that cover the nerves and intracranial structures. The meningeal irritation mechanism isn't known, but it is believed to involve the trigeminal nerve. Next chart is a little bit more extensive. It shows the pathogenesis of meningitis in a detailed format and how it spreads. Blood culture and sensitivity should be collected to identify an appropriate broad-spectrum antibiotic. Shown here are labs for both bacterial and viral meningitis using CSF as a reference interval. The normal values are shown in red. You'll see increased pressure for both, increased white blood cell count and protein for bacterial meningitis versus normal labs for WBC and protein in viral meningitis. Glucose is decreased below the normal range in bacterial meningitis, but normal or low for viral meningitis. CSF fluid is collected and indicates bacterial meningitis if cloudy and viral meningitis if clear.
Some common clinical manifestations that will be seen in meningitis are headache, which becomes progressively worse and may be accompanied by vomiting and irritability, nuchal rigidity or neck stiffness, photophobia, and decreased level of consciousness. Altered mental status is mostly caused by intracranial pressure, which is the most common acute complication of bacterial meningitis. More severe clinical manifestations include coma and seizures. Coma is associated with poor prognosis and occurs in 5 to 10% of patients, and seizure occurs in 1/3 of all cases. A common manifestation specific to meningococcus is skin rash and petechiae. Bacterial meningitis is a medical emergency, therefore rapid diagnosis is crucial when meningitis is suspected. Antibiotic therapy is instituted after the specimens are collected before diagnosis is even confirmed. Some IV antibiotics that may be administered are ampicillin, penicillin, and cephalosporins. Codeine is administered for headaches, acetaminophen or aspirin for a temperature greater than 100.4 degrees Fahrenheit, and mannitol is administered for diuresis. Some other interventions include rest, IV fluids, and cooling measures. This can include ice packs, cooling blankets, and cold fluids to maintain a temperature between 32 and 34 degrees Celsius.
As far as nursing diagnosis goes, one of them involves inability to sustain spontaneous ventilation related to level of consciousness. This mostly deals with respiratory monitoring and collection and analysis of patient data to assure airway patency and adequate gas exchange. For this, we got 3 interventions that can be done. One of them, you have to have resuscitation equipment, including your oxygen, resuscitation bag with mask, and suction apparatus at the bedside. The equipment should be at bedside in case of respiratory arrest. The bag valve mask ventilation is recommended as the patient's secretions can contain bacteria. For the patient, they should stimulate if this patient is apneic. If no response, begin manual ventilations and call for emergency resuscitation. The rationale for this, the stimulation may encourage spontaneous respirations. If not, ventilation is necessary. Calling for emergency resuscitation ensures help in managing the patient in a timely manner. For another intervention, monitor heart rate and perform compressions if necessary. Because the apneic patient may have bradycardia resulting from cardiac hypoxia. Some other diagnoses involve risk for injury related to cerebrospinal fluid infection and potential sequelae, which basically means just like other infections that could be happening or other processes related with the infection or risk for infection related to pathogens in the cerebrospinal fluid. So this deals with complication monitoring. We want to evaluate the fever, the shock, and consciousness responses to bacterial infection of the meninges. So some interventions would be to administer antibiotics or corticosteroids as scheduled. This would help eradicate the pathogens and prevent cerebral edema. Should know any return of fever or irritability, monitor your vitals, assess for signs of increased intracranial pressure, measuring the head circumference just to treat the common signs and symptoms, monitor for SIDH and watch for, because symptoms of it can be avoided if you notice SIDH is occurring, and make sure you keep the patient on strict I&O, because low urine output with high specific gravity is a sign of fluid retention. And as far as, and the last 2 diagnoses involve impaired social interaction related to decreased level of consciousness, hospitalization and isolation, and pain related to meningeal irritation. These deal with 2 other exemplars of infection control and pain management. Infection control has minimizing the acquisition and transmission of infectious agents, while pain management is the alleviation or reduction in pain to where it's acceptable for the patient. For infection control, we want to give rifampin and ciprofloxacin provide prophylaxis for many bacterial pathogens responsible for meningitis. With pain management, you want to reduce different stimuli, which involves lights, tactile, and making sure that the environment is quiet, because any of that can disturb the patient, making it difficult for them to recover. Some further potential complications of meningitis involve disseminated intravascular coagulation, encephalitis, persistent fever, seizures, and syndrome of inappropriate antidiuretic hormone secretion. Severe bacterial meningitis may cause head and heels to bend backward and body to bow forward, also called opisthotonos, coma, and death. Prompt medical treatment decreases risk for brain damage and long-term complications, including behavioral personality changes, cerebral palsy, learning disabilities, and mental retardation, as well as partial or total loss of hearing, paralysis, vision, and speech. And as seen from this, meningitis can be very deadly if you do not respond to the symptoms right away, because it can kill within 24 hours. Meningitis has been known to have flu-like symptoms and signs. So if you find it for both the infants, children, and adults, if you see any of this, especially when it comes to hyperthermia, please contact your healthcare provider right away. Here's our references, and thank you for listening to our presentation.